So I want to start the course by talking for the remaining minutes that I have about standardization. In my view, surgeons, we have a handicap as surgeons because we're a self-selected group. We're self-selected in that when we go to medical school, the people who choose surgical specialties instead of the non-surgical tend to be surgeons who have big egos and like to think that they're smart and they can do it all on their own and they can invent things and they can devise new ways and it's my way. And I think this is a big handicap for the specialty because, as it turns out, standardization is the only way to ensure the highest level of safety and the highest level of efficacy. This is something which has been studied for years in other areas, and mainly in industry and in the airline industry, in manufacturing. And, the fact is that refractive surgery is as close as you're going to get to manufacturing in medicine, in that we're trying to do engineering of the cornea. We need things to be precise. Precision means repeatability, means standardization. And nowhere have we learned more about standardization than the airline industry. The airline industry has been really key in showing us the way to not only have standard operating procedures on how to do things, but to have standard operating procedures on how to do things when they're not routine. I saw a pilot this morning who I had done presbyond on, and we were discussing that I was going to start teaching this afternoon. My first lecture is on standardization. And let me give you an example. He's a British Airways pilot, and so I asked him, in a year, what are the chances that you, as a captain of a 787, will fly with the same co-pilot in that 12-month period? And he said that the chances are about 1 in 400. So it's basically about once a year that they meet the same two people to fly a device which is full of people in the back and lots of fuel. So you can imagine that if there wasn't absolute standardization of not just what they do, but what they say and when they say it and the order in which they say it and do it. And we spent 5 minutes, it was like a love fest, talking about how this is really the key to safety. Can't emphasize this enough, but in medicine, we've been very slow to pick this up. Now, when I say slow, I mean in the 80s, because in the last 10, 15 years, there are a number of authors now that have started to write about checklists and standard operating procedures. And in fact, this now becomes thankfully, this is almost essential reading if you're applying to medical school for interview practice. And the airline industry has this, they've coined the phrase crew resource management. That is, crew resource management is the overarching term for standardization in the airline industry. And one of the elements of crew resource management, CRM, is followership. What is followership? Well, it's all to do with the organization. And it goes without saying that in society we have organized ourselves in all kinds of groups and nuclei and wider groups with a hierarchical structure. And because we recognize that for optimal decision making, you need one person to be the actual decider at the end of the discussions. And it doesn't mean that the decider is the most important person. In fact, the system depends on everyone within the organization working together, and the credit, of course, goes to the organization, but obviously the fault, if something doesn't go right, there has to be some responsibility taken, and that usually is taken by the leader. But the rest are followers. And followership is an attitude where every person in the organization is working as if they were, the most important person for themselves, but they're in the organization. And having this followership psychology is different because the follower will do the hard work and work 110% without the star billing of the front man or the captain or the president or the prime minister who, on whose shoulder everything falls, whether it goes well or not. So having this structure where there's a recognized decider is, it can be democratic, so this decider can change over time. And within these structures, there's something called a hierarchy security developed. And what this is a gradient from the top that goes down within the organization. And one example of how this hierarchy security is essential is where a subordinate has to feel comfortable with speaking up to a superior about a potential error, for example. And the superior has to be open to the subordinate pointing out a potential error. The pair will then acknowledge that there's a discrepancy and they'll have to discuss this. But of course, the decision has to be made by the decider. And in this process, the supervisor needs to understand that when his authority was questioned, it was not because of a questioning of his authority, it was a questioning about to produce a discussion for him to make a better decision. So it need not to be a threat to be questioned. And at the same time, psychologically, because we're all humans, it's important that the subordinates understand how the correct way of questioning the orders from a supervisor, because you don't want to set up a psychological barrier for this process to work properly. Matthew Said wrote a book on the airline industry, comparing it to the medical industry. His wife died very tragically because of a lack of hierarchy security in a room where she was having a routine procedure. If you read the book, the first chapter is quite taking. And he's a bit extreme in his generalization of the medical industry, always hiding its errors, never admitting to them. I mean, we're going to spend the next 4 hours, much of which is talking about complications. I'm not hiding my complications. I'm showing them to you so that you don't repeat them. So, I think it's a little bit extreme, but I think his book has a very, very good message, which is that every error that we manage to, or any failure that happens when we're operating, needs to be examined in great detail, because there is information inside that which leads us to be able to learn how to avoid that at another time. So it's not a threat, it's an opportunity. And the point here is that standardization enables us to go beyond averages. So in an average system, if surgeons are doing a smile 15 different ways, 15 different parts of the technique are done differently, the average results are going to be pretty much the same because of the law of averages. But the point about standardization is to reach the outliers and make those as infrequent as possible. So an example here is the use of instrumentation. There are about 20 smile instruments on the market, and that's a bit chaotic because it causes, as you will learn in a couple of weeks' time, it causes a lot of discrepancies in the techniques for removing lenticulae, and it can generate complications. Whereas, as we will argue, if you use the same instrument with the same technique, well, if you're duplicating something, you're bound to get similar results and avoid outliers that would be caused by different instrumentation. So it's these outliers that we're trying to bring in. And, bizarrely, I've pulled these slides up from the year 2000, when I was just a few years out of my fellowship as medical director of LASIK Vision, the very first refractive surgery chain in the world. Michael Henderson was the charismatic leader of this organization, and we were brought up to the parapet because I was a bit of the pariah of the industry, because I was at the medical head of an organization that was discounting LASIK, and it was causing a hell of a lot of problems actually within the community. I was brought up against Steve Slade and Dick Lindstrom, which was, not a pleasant experience, as you can imagine, as a young, up-and-coming clinician, scientific clinician. But I went up there and I presented data, and I was showing here a slide of, the outcomes of over 25,000 eyes during a period of 3 months. I've had this slide talking about what the ideal provider would be. And as you can see, I was already talking about a cohesive body, no superstars, training and accreditation, standardization in primary procedures or complications, ongoing education, open communication about errors, having a high volume of surgery to gain the experience and expertise, and to be able to have basic science knowledge to be able to solve situations that you might not have come across before based on your expertise. And we finally managed to publish a paper on the data that we collected. We had about 90,000 patients. We had a 50% sample, so it was about 45,000 eyes. And the interesting thing was that there were 6 surgeons in the organization of 60 who refused to take the standardization course that we had set up. And they refused because they were older, and they said they'd already done thousands of procedures and they're not going to waste their time taking the course. And I was at the time very upset about this, but I'm now very grateful for their stubbornness, because they were able to demonstrate that the efficacy without training was lower. The predictability without training was lower, and the safety without training was lower. So it was a mass experiment that would be very difficult to repeat. But all to say that standardization is really where it's at. And I think one of the things that people object to when they say, well, I don't want to do it a standardized way because I'm brilliant. I have ideas. I want to develop the technique. I don't want to be, stuck in a standard technique. And this is a complete misunderstanding of the concept of standardization. Standardization means standardization. It means setting a standard. That means a high standard, not a low standard. And so it doesn't mean boring and inflexible. It means the same way so that you can build on it, and you can build innovation into standardization while you're giving patients the same safety and essentially a guarantee of a level of safety which has been measured using that technique. So we want to think about the standard technique as not London Vision Clinic technique, not Dan Reinstein's technique. It's a standard that's above us. It's a standard that we all look up to, we all feed it, we all respect it. And if there is something to change, well, we can change it for all. So an improvement can therefore be generalized around the world very, very quickly. If everyone's doing something differently, and somebody has a brilliant idea that gives him better outcomes, well, that's not going to be applicable to the others if there are too many different things going on at once. Whereas if everyone's already operating with a standard technique and there's one piece of brilliance that comes out, that can, of course, then be fed and brought into the group, and everyone benefits from it. Of course, this means also that with standardization, you can teach better. So it took me, I would say, about 10,000 procedures to get to the level where I could teach Glenn Karp to do LASIK the way I did in 1 year. And the accumulation of knowledge was because I was in a very shallow learning curve, because there was just too many things that were different, and different opinions about what could be done, and should you irrigate under the flap or not, and there was just so many different opinions about how things should be run that the learning curve was very, very flat. Whereas now we can take a course like this and give you 22.5 hours of instruction, And I will be surprised if even the most experienced surgeons amongst you will not come away saying, wow, I really gained something from this because of all of these concepts that we're going to be talking about in the next 5 sessions over the next 5 weeks. So, I hope that this kind of gives you a little background into our kind of militant approach. And we don't mean that there's no innovation. We just mean that the more we can standardize what we're doing, the more likely we are to be able to give our patients statistics that mean something on our level of safety, and therefore, be able to practice at a standard which we can impart and get proper informed consent for.